Hi, I'm Dr. Brie Radis, and I am here to present recommendations for Housing First in Philadelphia. Philadelphia is currently the poorest urban city in the United States, and my Housing First journey began 15 years ago. I started off as a case manager and ended up being a supervisor, a team leader, finally the clinical director of 5 different teams, and then a clinical supervisor. And currently I'm a consultant because I'm teaching full-time on social work faculty at a large public university. So the Housing First basic tenets are that housing is a basic right and that individuals have self-determination choice throughout the process. We provide scattered housing. We operate within a model of housing not being time limited. We use this model here. This image is from Pathways to Housing, the program we were modeled after. Here you can see a homeless individual goes right into permanent supported housing and then is able to get all of their needs met, as opposed to the traditional housing readiness model where individual has to do certain things before they can qualify for housing. These are some of the main theories that we use every day in Housing First. Ecological systems theory, we're basically supporting individuals to interact with all these different systems in their lives, whether it be criminal justice or mental health, the medical field. And we're working with them to support them on their dreams and their goals, whatever that may be, even when they're in crisis, and trying to really focus on ways to solve the problem. And we're operating from that person-centered approach where we're treating every individual with dignity and respect. And here's Abraham Maslow's hierarchy of needs. And you can see there at the bottom the physiological needs, and that's really where Housing First starts. We really work to do that so individuals then can go and feel more safety to then get a job, go to the doctor for the first time in 20 years, reunite with family members. Harm reduction, which I mentioned earlier, is one of the most controversial aspects of our program. And we're meeting individuals where they are, and we're being very non-judgmental about their use. And if an individual is ready to reduce their use because of the consequences that they're experiencing, we work with them to find safer substances or ways to use. And that's a really important part of the fidelity of the model. So when I was, this is a great continuum model of what harm reduction can look like, going up and down the stairs, not staying in one stagnant spot. So there's so many benefits in the literature about Housing First. The main one is that it saves a lot of money. There's often decreased hospital stays. Individuals, 75 to 80% are in housing, even after a few years of being starting the program. And it's often effective with a very fragile, fully diagnosed population. So why do individuals often lose their housing? Why is it not successful? It could be many issues. Often there's lease violations that the team really helps to work with the participant on, such as hoarding, not paying their bills. Often we try to become the payee. There could be lease violations such as traffic or unauthorized individuals living in the unit. And that often may result in the lease being terminated. Also, the apartment is often lost, maybe due to the individual entering into prison or treatment. And if that's over 90 days, then they do also lose their apartment. So what have I learned when I was processing what are the best practices for Housing First? It's not from the literature, but it's from my lived experience. And I would say the importance of trauma-informed services. This really relates to staff retention. When we started doing more trauma-informed services and clinical supervision, I saw a change in that within my team. Also, the importance of fidelity to the model. I think Housing First is such a buzzword. People use it a lot, but it's often not compared to the checklist of what Housing First was created in that evidence-based model. It's the importance also of staff training, making sure that we train everyone in motivational interviewing, that we train everyone in trauma responses, and we also hire people that are able to do the coordination of services in a successful way. And that really relates to when we see a gap in what the participants need, then finding a program that would really be a good match. For instance, partnerships with outside entities, we were able to find funding to have a medical clinic within our building for participants that did not want to go to outside medical care. And also the importance of this program is really related to harm reduction and the connection to social justice. And finally, these are the next steps for Housing First. What are the next steps for research? Here's where I see it. Housing First for families and couples, what does that look like? How does it work? What happens when we don't have fidelity to the model? What about Housing First 2.0? Now that we've had it for a while, what are the case studies, the best practices for individuals who haven't been successful? What are some interventions we can use and share with other programs across the world? Because Housing First is international at this point. And then Housing First and aging in place, really important to see for individuals who are often 50 years old on their birth certificate, maybe presenting as a 75-year-old, how can we support them to age in place in their apartment? And then finally, as the drug use epidemic keeps going on, getting worse, how can Housing First really fulfill this gap? And then here's some references and resources. I'm happy to email anyone this presentation, Brie Radis at wcupa.edu. If you're interested in partnering with research, happy to also work with you. So thanks so much.